Good
Oh,
afternoon, good evening, everyone. On behalf of the Asian Congress of Neurological Surgeons, it's my great pleasure to welcome you to the ACNS Haneda MVD Forum webinar dedicated to microvascular decompression in neurosurgery. Today, we have an excellent academic program with distinguished experts in the field of microvascular decompression. It's my great honor to introduce our chairs for today's session. Professor Yoga Kato, Professor of Neurosurgery at Fujita Health University, Bantane Hospital, Japan. Professor Hinyu Yang, Deputy Chairman of Neurosurgery at Tianjin Medical University General Hospital, China. And it's my great pleasure to introduce our first speaker, Professor Fuminari Komatsu from Department of Neurosurgery, Fujita Health University Bantane Hospital, Nagoya, Japan. He will present endoscopic microvascular decompression, a new trend of endoscopic keyhole surgery. Our next speaker is Professor Yan Zhao from Tianjin Medical University General Hospital, China. He will present on microvascular decompression. Our discussant today, Professor Hiroki Toda from Kyoto University, Japan. Now I would like to invite our chairs, Professor Hinyu Yang and Professor Yako Kato, to give their welcome remarks.
okay. Professor, are you here? Kato Sensei.
Kato Sensei will not be joining, Prof. Yang. Please go ahead and give your opening remarks.
Okay, thank you, Raja. Today, we are very honored to have our two speakers and two discussants under the direction of Professor Kato. We have a very honored chance to learn from some very skillful and very famous neurosurgeons to learn from their endoscopy and microscopy surgeries. It's a very nice chance for young neurosurgeon, and it's we are very honored to have all to honor the discussants from these webinars of we invited from several different countries. We can learn from each other, and I think this is a very good chance, and for all over the world of the young neurosurgeons, and it's my great thankfulness to Professor Kato and ACNS and to Professor Raja Kuti to organize this wonderful video webinars to give us the chance to join together. So thank you very much.
Okay, thank you, Professor. Now we will start the scientific session. Professor Komatsu, please start your presentation.
Thank you, Dr. Mouth. It's my pleasure to meet you online.
Yes,
So yes, I'd like to share my screen.
Okay, please.
Can you show my screen?
Yes.
Can I show? Can I?
Okay, wonderful.
Oh, can you see that? Okay.
Yes,
So,
okay.
okay.
Good.
My topic today is the endoscopic microvascular decompression for trigeminal neuralgia and the hem facial spasm. So, I'm from Fujita Health University Bantani Hospital, Nagoya, Japan. I studied endoscopic keyhole surgery and keyhole anatomy in Vienna, Austria, more than 10 years ago, and then started endoscopic keyhole surgery. And now I'm working at Fujita Bantani Hospital, and I like to show our method of endoscopic MVD. So patient is placed in the park bench position, and this is the skin incision. The skin incision made behind the mastoid process. The trigeminal neuralgia and the hem facial spasm is a little bit inferior to trigeminal neuralgia. After skin incision, 3 to 4 centimeter skin incision, the soft dissection was done, and retrosigmoid keyhole, approximately 1.5 centimeter keyhole is made. And 4K ICZ endoscope is used. and the endoscope is fixed on the pneumatic endoscope holder. Single shaft instruments are mainly used. Decompression method is classified into two methods, interposition and transposition. We basically do the transposition, and the transposed artery is fixed with fixed with fibrin glue only. This is easy and suitable for endoscopy. This method is already reported from the Mayo Clinic. The fibrin glue is a reliable method. After procedure, the dura is crossed with duragen, and bone defect is replaced with bone cement. So I show some restorative cases, initially of trigeminal neuralgia. This is a trigeminal neuralgia website. On the 3D image, the SCA is offending vessel. Here's a skin incision. After a small keyhole craniotomy, and then endoscope inserted. Now we can see the trigeminal nerve. It's compressed by the SCA. ECG is given. The artery is highlighted. So after arachnoid dissection, the SCA is identified and mobilized and separated from the trigeminal nerve. It was completely mobilized and attached on the tentorium with fibrin glue. This is a very simple technique and easy, and SCA is fixed on the tentorium, and in this case, the trigeminal nerve is separated from the petrosal vein. This is final view. These are pre and post-surgical views. And the next case, the similar case, but the petrosal vein restrict the visualization of the trigeminal nerve. Even such case, that endoscope provide a better view for the trigeminal nerve. ICG is given, and offending vessels are identified. And then the SCA is again mobilized and attached on the tentorium. And then the endoscope showed the trigeminal nerve and the surrounding structure so beautifully, even behind the petrosal vein. The next case is trigeminal neuralgia. Offending vessel is a trigeminal cerebral artery. Trigeminal cerebral artery is a normal variant artery. It arises between the SCA and the ICA. I show the video. In this case, now we can see the trigeminal cerebral artery. It's penetrate the trigeminal nerve near the Meckel cave. SCA is also running on the trigeminal nerve. So that's why the SCA is initially decompressed and attached on the tentorium again. And then the proximal side of the trigeminal cerebral artery is fixed with the dura. But decompression, transposition was incomplete because it has many perforators. So interposition was also performed. And then the third part of the trigeminal cerebral artery is mobilized and fixed with tentorium with fibrin glue. These are final view. Again, the ICG is given. The trigeminal cerebral artery is highlighted. These are pre and post-surgical views. Next is the hemifacial spasm. For the hemifacial spasm, 30-degree endoscope is used. I show some illustrative cases. Initial case is the hemifacial spasm right side, and the ICA is offending vessel. Here. So this is skin incision. And then small keyhole is made. And between 8th and the 9th cranial nerve, 30-degree endoscope is inserted. Now we can see the ICA running on the facial nerve. This ICA is carefully mobilized and lifted and attached on the dura with fibrin glue again. And ICA is tightly fixed on the dura. And now we can see the indentation on the facial nerve. And all perforators are well preserved. Complete decompression was achieved. These are pre and post-surgical views. Next is the hemifacial spasm left side. ICA-PICA common trunk. That is the offending vessel in this case. This skin incision. And the keyhole is made again. And between the 8th and 9th cranial nerves, the 30-degree endoscope is inserted. The ICA and the PICA, they are covering the facial nerve. We cannot see the facial nerve at this moment, but after mobilization of the ICA, now we can see the facial nerve partially. So the decompression started from the ICA. The ICA is attached on the dura gradually. Now we can see the facial nerve. So this is the bifurcation of the common trunk. It's also attached on the dura. And the pica branch is also tightly attached on the dura with fibrin glue. And this is after decompression. We can see the indentation and the perforators are beautifully shown. These are pre and post-surgical views. The next case is the hemifacial spasm left side. The vertebral artery is offending vessel. This is skin incision and keyhole. And then again, the 30-degree endoscope inserted. And, we can see the vertebral artery running on the facial nerve. So this vertebral artery is lifted and attached on the dura with fibrin glue again. Fibrin glue is applied a lot, and then we can see the facial nerve. Indentation is also seen on the facial nerve. These are pre and post surgical views. So far, more than 800 endoscopic MVD cases are experienced in the last 5 years. So this is the surgical result in 2024. The classical trigeminal neuralgia. It's sure that 94.5% sure that excellent and good result. Excellent result was shown, and also for the hemifacial spasm. More than 90% cases show the excellent and good result. As for complication, hearing loss was only 1.1% in more than 800 cases. 0.1 points case had trochlear nerve palsy. CSF leakage requiring repair surgery was 0.4%, and the wound infection requiring debridement was 0.5%. For discussion, the endoscopy or microscopy. Some literature shows that the endoscopy is better than microscopy in terms of the surgical result. But others said that between two groups, I mean the endoscopy and the microscopy, there's no significant difference in surgical results. So this article has a different view. It says that in surgical results, no significant difference was shown, but less post-operative headache was seen in endoscopic group, suggesting that minimally invasive surgery can be performed, endoscopic surgery. So between endoscopy and the microscopy, it's still controversial whether endoscopy leads to significantly improved surgical outcomes, but probably endoscopy presents notable difference in terms of its minimally invasive nature. So this is my conclusion. Endoscopic MVD will be the standard modality in the next generation. Thank you for all your attention.
Thank you, Komatsu-sensei, for your excellent presentation. Now we will open the floor for discussion. I would like to invite Professor Hinu Yang to start the discussion.
Okay, thank you. Very wonderful presentation. Thank you very much, Fuminari Sensei. And I see very beautiful videos and the sense is only neurosurgeon can see those the cranial nerve and the vasculars, and with the endoscopy, but we can see more details than microscopy. And to my question is, I'm very interesting, is that what kind of fabric glue you used to stick the vascular to the tendon? In my city, we don't have that kind of glue. Can you introduce the fabric glue more detailed? Thank you.
That's ordinary product in Japan, not special.
Okay.
That is usually used for the closure of the dura or something. Any particular differences there?
Do you worry about that the glue is will be dissected and the vascular return to the position before surgery?
No, I'm sorry.
My question is that I'm worried about the effect of the glue.
Infection.
Maybe infection. Maybe I worry about this. The stick can the vascular to be stick very firmly to the dura. Maybe dissection happened. Is that there any
A dissection of the artery? You mean the after mobilization?
Yeah. Yes. Not a vascular injury. I mean that the vascular may be detached from the
detached
from the dura.
Yeah. I showed the article. It also says that attach with the fibrin glue is reliable. Yeah, I think so. That I mean, the important thing is the vessel must be fixed with the long distance. So, so attachment, how can I say? The artery must be fixed in the long attachment.
Yeah. Sometimes in my experience, sometimes the vessel is some longer distance between the vessel and the dura. How long is the longest way you can perform the
I understand your opinion.
Okay.
Of course, such case, it might be impossible. In that case, of course, I use the Teflon felt to fix the vessel. Yeah, another. So that's the first strategy, the fibrin glue only. But if it's impossible, in that case, I use the Teflon felt for the fixation.
Okay. Okay, thank you. That's my question. Thank you very much.
Okay, thank you. Professor Hiroki Tode Sensei, do you have question?
Well, thank you very much, Professor Komatsu. Your presentation always wonderful, and this time I'm very amazed your great technique and excellent outcomes. I congratulate your success. So, I'm happy if I could hear some details on how do you place your keyhole for the trigeminal neuralgia and for the hemifacial spasm. Could you add a little more illustration or explanation of your technique or to how you place the keyhole?
Oh, thank you very much.
Location.
I analyzed the CT scan very well before the operation. For example, the location of the emissary vein and the location of the digastric groove or something like that, and decide the placement of the keyhole.
Okay. It seems to be you refer to inferior nuchal line for the keyhole placement for the hemifacial spasm. Is that correct? You show the inferior nuchal line on your scheme.
Superior and inferior to superior nuchal line is opened for the hemifacial spasm. Trigeminal neuralgia, only the superior part, superior to the inferior nuchal line, is opened for the trigeminal neuralgia.
Do you expose the edge of the sigmoid sinus, or you don't care?
I confirm, but no need to expose completely. Just partially, I just confirmed.
And also, we really appreciate your great technique of using the, it seems to be a ball dissector to mobilize the
yes.
ball dissector.
And it's also the flexible.
Flexible.
We can change the angle of the dissector. So that's very useful for this kind of surgery.
Okay. What kind of scissors do you use for arachnoid cutting?
I use the single shaft scissors, the Geister, the Geister product of the Geister.
Okay.
But usually the Geister product, I think the length of the shaft is 12 centimeter. This is designed for the pituitary surgery. But I use the 9 centimeter shaft of the Geister scissors. It's only designed for this MVD surgery.
I see. Okay. Well, thank you very much for instructing the detail.
Thank you very much.
Thank you.
Sensei, I have one question. In cases of no clear neurovascular conflict is identified interoperatively, what's your preferred surgical strategy?
Yeah, that's most of the cases probably the trigeminal neuralgia you encounter. It's diagnosed as idiopathic trigeminal neuralgia. In that case, usually the internal neurolysis is done. Internal neurolysis is making an incision. Yeah, I mean the split the neural fiber is performed. Usually 2 or 3, usually 3 incisions are made on the trigeminal now.
After this procedure, patients feel like facial numbness, like complications. It's not.
Yeah, if you make too many incision, in that case, patient might have the numbness or sensory disturbance. So that's why I only make 3 incision. So more than that, I a little bit scary for the complication.
Okay. Thank you, Sensei. To the audience, if you have questions, you may ask.
Komatsu Sensei, I have one question. In our practice, we still frequently use Teflon interposition. Do you still use Teflon in some cases, or do you mainly rely on glue fixation now? And when the offending vessel is a large artery, such as the vertebral artery, do you think the glue fixation is strong enough to maintain a long-term stability.
Yeah, thank you very much. As I said before, the fibrin glue is the first strategy, and if it's impossible, in that case, I use the Teflon felt for large vessel, as you said. But as much as possible, I do the transposition, and then the fix with the fibrin glue and the Teflon felt, and if the transposition was impossible, in that case, I do the interposition, for example, the short perforator or something like that.
Yeah, thanks very much.
And
Thank you.
one question from the audience, I will read. How long may fibrin glue remain? Does it not get absorbed? Dr. Keke Turel asked by chat.
Thank you very much. I did redo surgery in some cases after the transposition of the vessels. In such cases, the fibrin glue is already resolved, nothing. But the vessel is fixed on the dura or tentorium with connective tissue. Probably the fibrin glue is replaced by the connective tissue. So I think the effect is permanent.
Okay. Thank you, Sensei. So if no questions, let's move on. Next speaker to invite Professor Zhao to speak on microvascular decompression. Professor, please.
Can you see my screen?
Yes.
Okay. Good evening, dear colleagues and friends. Thanks very much for the opportunity to share our experience on MVD surgery. My name is Zhao from Tianjin Medical University General Hospital. Today I'm going to talk about microscope-guided MVD surgery, focusing on surgical relief for trigeminal, neuralgia, and hemifacial spasm. Neurovascular compression syndrome may mainly referring to situations where a blood vessel repeatedly contacts a cranial nerve and triggers symptoms. So the purpose of microvascular decompression is very straightforward. Remove the microvascular conflict, stop the pulsatile compression, preserve the nerve, and aim for a durable cure without neurological deficits. I think the true decompression means separation, not just placing Teflon while the vessel is still pushing on the nerve. The second point is accuracy. We have to always focus on the root entry zone because that's where the nerve is most vulnerable. In trigeminal neuralgia, the offending vessel is usually superior cerebellar artery, while in hemifacial spasm, the offending vessel is usually ACA or vertebral artery. The primary mission is to find the true offending vessel. When we understand the principles of the surgery and master the correct surgical method, the efficiency of the surgery will increase, and the mortality and the complication rate of the surgery will be reduced. In MVD surgery, the offending vessels can be separated into two types, in my opinion. A primary offending vessel directly comprises the root entry zone, sometimes leaving a visible indentation, and that vessel must be fully decompressed. A secondary offending vessel may not press directly on the root entry zone, but it can lock the primary vessel in place. If you ignore it, the decompression can fail because the main vessel cannot stay immobilized. So you have to identify both and manage them strategically. In decompression surgery, the strategy really depends on how the vessel is interacting with the nerve. There's no one size fits all method. It's basically there are a few different ways I try to achieve good decompression, such as sling technique, bridge technique, layered method, etc. I think no single technique works for every patient. I try to stay flexible, but the goal is always the same, stable, long-lasting decompression. Here are the situations that make decompression challenging. For example, vertebral artery, cortical ectasia, reoperations, a narrow posterior fossa, petrosal vein obstruction, dense perforators, and other special anatomical constraints. So we do a reason analysis before surgery. Sometimes the superior petrosal vein can get in the way of surgical exposure, especially in trigeminal cases. As a general rule, I try to preserve it. If the vein looks like a major brainstem draining vein, appears arterialized, or has very few lateral branches, I avoid cutting it whenever possible. If the exposure is still limited, I'd rather adjust my working angle, release more cerebral spinal fluid, or allow better cerebellar relaxation than sacrifice an important venous outflow. In certain situations, if a critical vein truly blocks the corridor, I will look for alternative strategies instead of forcing the way through. For hemifacial spasm, electrophysiology monitoring is a crucial assistant technology. Abnormal muscle response, also called lateral spread response, is widely used, but I think it's not very perfect in the literature. The positive predictive value when the response exists can be relatively low, while the negative predictive value when the response disappears is much higher. Sometimes it's hard to induce. Sometimes it appears early and sometimes it appears late. So in my opinion, don't rely on electrophysiology alone. Treat it as supportive information, continuous, dynamic, quantitative stimulation rather than a single yes or no check. This is how we monitor AMR. For hearing preservation, monitor brainstem auditory evoked potential is very useful. Recommend multi-parameter alarms, for example, changes in the V-wave amplitude and latency, and the IV peak latency, but always remember there can be a delay effect. Sometimes injury happens before the alarm reaches the threshold. So sensitivity can be high, but specificity can be limited. In selected cases, electrocochleography can give more information about cochlear function. We use monitoring, but we still have to operate gently, minimize traction, keep the field relaxed, and respond early when the waveform starts trending the wrong way. The surgical position, supine, lateral, or park bench is also possible and can be chosen based on the operator's habits and the patient's own anatomical features. The design of the surgical incision and bone window can be determined by the type of the surgery and the anatomical features of the patient. To avoid missing the funding vessel, we can divide the cerebellar planting angle into four gaps. And this method can help to explore the offending vessel efficiently. For trigeminal neuralgia, we mainly work in gap 1 and gap 2. For hemifacial spasm, we usually focus on gap 3. For glossopharyngeal neuralgia, focus on gap 3 and gap 4. And this structured exploration improves efficiency and safety. Now I will show two cases. This First one is a 56-year-old woman with classic trigeminal neuralgia. Shooting pain in the right V2 distribution. It has been going on for 3 years and is treasured by brushing teeth and washing her face. On the preoperative imaging, we can see a suspected neurovascular contact on the symptomatic side. Here's the video. Under the operating microscope, the cerebral protein angle is exposed. The retinoid is opened carefully to release cerebral spinal fluid. And this step improves visualization and relaxes the cerebella. Cranial 5 and 8 were identified. Attention is directed to the trigeminal nerve. Offending artery is seen compressing the nerve. The compression occurs mainly from the medial side. A cranial component of compression is also present. The trigeminal shows a sharp turn near the root entry zone, and several small perforators entering the brainstem and are visible. The neurovascular relationship is complex. To create adequate working space, vascular mobilization is required. The superior cerebral artery is carefully deserted. The vessel is mobilized toward the tentorial surface. Further dissection is performed along the pointing segment. Small perforating branches are encountered. Some tiny branches are sacrificed to increase vessel mobility. Care is taken to preserve the important perforators to the brainstem. Once mobilized, the offending vessel is transported away from the trigeminal nerve. The compression is fully relieved. A segment of artery passing through the nerve is wrapped with a small Teflon. Post-operatively, the patient recovered well. Facial pain disappeared right after the surgery. The second case is a 66-year-old man with a 2-year history of hemifacial spasm. This is also a very typical cause, progressive unilateral facial twitching consistent with chronic root entry zone irritation. Here, the vascular imaging suggests the prominent vertebral artery configuration near the brainstem. Here is a survey video and the operating microscope. The cerebral pointing angle exposed. The retinoid membrane is opened sharply. Cerebral spinal fluid is released to relax the cerebellum. Gentle cerebellar retraction provides a clear operative corridor. Cranial nerve 7 and 8 were identified. Attention is directed to the root entry zone of the facial nerve. In this case, the vertebral artery is seen compressing the facial nerve, and the vessel forms a strong medial to lateral compression against the nerve root. The pulsated artery directly contacts the facial nerve at the brainstem. This region represents the vulnerable transition zone between the central and peripheral myelin. This set is commonly responsible for hemifacial spasm. Careful retinoid dissection is performed around the vertebral artery. The vessel is gradually mobilized. Several small retinoid adhesions are sharply divided. Special care is taken to preserve these perforators supporting the brainstem. Because it's a large caliber and strong pulsation, the vertebral artery shows limited mobility. Additional dissection is performed along the arterial wall. The step increase vessel mobility, and this creates a durable separation between the vessel and the facial nerve. Finally, the facial nerve root entry zone is now completely decompressed. Postoperatively, the patient experienced the immediate relief of facial spasm. No neurological deficits were observed. Here, I would like to share another case. This is a recent surgical video posted on YouTube by Professor Lawton. This is also a patient with hemifacial spasm due to vertebral artery compression. Dr. Lawton linked the vertebral artery to the dura mater with an aneurysm clip so as to relieve the compression. I think this is a very interesting and creative surgical technique. In the future, if I meet a similar case, I think I will try this method. Interested colleagues can find the video on YouTube. Beyond trigeminal neuralgia and the hemifacial spasm, neurovascular decompression has expanding indications like glossopharyngeal neuralgia, geniculate neuralgia, disabling tinnitus, neurogenic hypertension, and some selected ocular motor disorders. I think microvascular decompression is evolving from a very selective operation into a broader framework for comprehensive cranial nerve decompression, of course, with careful patient selection. So to conclude, microscope-guided microvascular decompression remains a proven etiological treatment for trigeminal neuralgia and hemifacial spasm with substantial symptom relief and quality of life improvement. Looking forward, better imaging, better tools, and smarter monitoring will keep improving outcomes. And clinically, I think early diagnosis and timely referral are still key. So eligible patients can get definitive treatment sooner.
Okay, thank you very much, Professor Jan Zhao, for excellent presentation. I would now like to invite our chair to lead the discussion. Professor Hinyu Yang, do you have any question or comment?
Okay.
Please.
Thank you, Maruf. I working with Dr. Zhao in the same department. In our department, we have at least 2 or 3 neurosurgeons working with endoscopy, and 5 to 6 maybe neurosurgeons working under microscopy for MVD patients. And so we, in our department, we can compare the endoscopy and microscopy in one center. And I think the difference is very different, because the manuscript, the action of hands manipulate the scissors or forceps are quite different. These are very distinct difference training course of operation under microscopy or endoscopy. I think the muscle memory are quite different, and if a doctor training under microscopy and shift to endoscopy, need to start a new training course and learn as a new beginner. I do not have too many experts of endoscopy. So I hope Professor like Fuminari give more advice on endoscopy. So thank you very much.
Okay, thank you, Professor. Professor Hiroki Toda, do you have question?
Yes, thank you very much for your great. So starting from the great review of the principle, the pathophysiology, and also a basic surgical technique and the surgical principles. It's a quite nice review and very helpful to refresh my memory. So. So you showed the both disorders, trigeminal nerve and hemifacial spasm, and you showed the interesting to me. You showed you showed four gaps for the entry point to the dissect further near the each nerve. Well, according to me, I also use the gap 4 for hemifacial spasm often because we like to see the root of glossopharyngeal nerve to confirm the neurovascular compression near the at the root exit of the facial nerve. Do you have any comment for that?
Oh, about the four gaps is from the literature, and we see. I think it's very useful for trigeminal nerve surgery and the special and the hemifacial special surgery. And for glossopharyngeal surgery, I think it's also useful. The four gaps give us a separated space of the cerebral protein angle, and the offending vessels mainly are in the specific gap. So we can check the four gaps to look to find the offending vessel. I think it's useful for efficiency and safety. This is my opinion.
Okay, yeah. So gradually, I moved forward to moving to the more mainly using gap 4 for doing the hemifacial spasm. Well, maybe my initial experiences, I might use the gap 3, but realized the more approach from the more caudal side. So that's the reason I prefer to use the gap 4 to do hemifacial spasm as well. Yeah, but thank you very much for your comment and the reply. Yeah.
Thank you. And I have one question. Petrosal vein, sacrifice of petrosal vein, is it allowed, or during the surgery we should preserve petrosal vein?
Petrosal vein.
What? Yes, petrosal vein.
In my opinion, petrosal vein is very important. You have to reserve it in any situation. I don't cut petrosal vein in any time. It's very important.
Okay, thank you. And for interposition technique, can we use muscle instead Teflon? What do you think?
I think muscle can muscle. I don't use. I don't have experience using muscle. I think muscle is a better way because muscle can how do I say muscle can resolve.
Absorb.
Yes. Muscle can absorb. The Teflon is unabsorbable.
Okay, thank you. Komatsu Sensei, do you have any comments or question?
Yeah, thank you. Thank you for your presentation. I was interested in the video of the trigeminal neuralgia you showed. Probably initially the SCA was transpositioned in the video. And then you manipulate another vessel around the trigeminal nerve. I was not able to understand what was the vessel, the ICA or trigeminal cerebral artery or venous system. How do you think it?
I think it is mainly from the icon.
ICA.
Yeah.
So because that artery was running between the motor root and the sensory root of the trigeminal nerve. It looks like that.
Yeah.
I'm not correct or not?
In the trigeminal neuralgia surgical vertigo, I think the offending vessel is mainly from ICA, and there also have another small vessel is a secondary offending vessel. It's a little complex.
If I can comment, as Professor Komatsu mentioned a little bit about it, I think it's a trigeminal cerebral artery, TCA, because they send the small perforators, and Professor Zhao carefully manipulate, and one of them you cautiously cautery and cut it, and so from that observation, I think it's a TCA, and I thought you very technically mobilize that artery. That's my impression.
Thank you very much.
Thank you.
To the audience, if you have questions, you may ask. Dr. Harshad Parekh, you asked a question from chat. You can ask now.
Hello, excellent presentation. While doing endoscopic assisted MVDs, you require your both hands to be used. Who holds your endoscope? Because endoscope training, holding training is also required. So who is the person who is holding the endoscope when you are doing endoscopic assisted?
Oh, can I answer?
Yeah, please.
Yes. Yeah, in our institute, the pneumatic holder hold the endoscope. That's why the assistant does not have the endoscope. But I know that in many places, the assistant hold the endoscopy. It's a little bit scary, but maybe the trained hand might be possible. But I recommend to use the endoscopic holder to ensure the endoscopic technique.
Is your endoscope holder is a pneumatic or it is just a robotic?
Pneumatic.
So with that, you can use the switch to bring the endoscope out and in.
Yes, right.
Mhm. Okay, right. Very nice. Very nice. Thank you.
Thank you.
Okay. Thank you to our both speakers, Professor Fuminari Komatsu Sensei and Professor Zhao, for the excellent presentation. Before we conclude, I would like to invite our chair, Professor Yang, to give the closing remarks.
Oh, thank you. I see the name list from the audience. Professor Kato is there. Can we invite Professor Kato give a speech first?
Yes, just a minute.
In the audience. Okay.
Okay. She has joined.
Yes, Professor.
Unmute, please, Professor.
Sorry, I just joined
Okay.
5 minutes before. I'm so sorry. I missed the two big presentation today. Thank you very much for chair. And I always watched Professor Komatsu surgery. it's really simple. Just less than 1 hour surgery, I think. And of course, the endoscopic surgery is very, very advanced. And also we can see very clearly, very high magnification. And also that we can check the whole around of the situation. I think that means is we hope the endoscopic surgery will extend for everyone can do it in the future, I think. And I'm so sorry because I cannot listen about Dr. Jan's excellent talk. I'm so sorry, but maybe I think your lecture was good, I think. So maybe anyway, then we can get the good point for each daily surgery, I think. Thank you so much. It was a wonderful talk. Jan, thank you so much for your good chair.
Yes, Professor.
Okay. If there are no further questions, we will conclude today's session. Thank you, everyone, for joining us.
Thank you.
Thank you.
Thank you.
Thank you very much.
Thank you. See you again.
See you again.
戸田先生、ありがとうございました。
いや、ありがとうございました。
はい。See you next
戸田先生、あ
time.
りがとうございました。